I would argue that as a matter of sort of the cultural politics of it, it's very difficult to extend one frame to the other territory, essentially, that these are two essentially separate territories. If you think about what are the sources of stigmatization, they come at multiple levels in the society. There are policy decisions, as I've already implied, by local or national governments, regulatory actions, public information campaigns can also stigmatize. We did a good deal of stigmatizing, for instance, as public health people around tobacco smoking, essentially, as a way of discouraging it. They can be decisions by social agents and agencies, attending often to the most problematic cases. And decisions often amplify the marginalization and the stigma. If you try to exercise some tough love and it doesn't succeed, then you've got to show how you really meant it, essentially. Intimate processes of social control and censure in the family and among friends is a third level at which stigma happens. They're often effective in changing behavior, but they may result in pushing people out of social contact, essentially. What's problematic? What is it that is the objects of subject-related stigmatization? The first and obvious collection of things is problems ascribed to use, illness or violence or casualties or failure in work and family roles. If you give a vignette about a man drinking more than he used to, can't cut down, becomes agitated, has become unreliable, and you ask US adults how likely is he to do something violent, then 71% of them will say somewhat likely. So that, you can see that, which is a higher percentage than for schizophrenia or for depression. And those with problems are often stigmatized by other heavy users. Joe Gusfield and his students went hanging around bars in San Diego and found that basically the heavy drinkers in the bars like to think of themselves as competent drinker. And their definition of a competent drinker was one who didn't get into trouble. So they spent an awful lot of time advising each other about how to drive home where the cops weren't likely to be looking out for them, because you didn't get in trouble if the cops never caught you. So that you find that, in fact, other heavy users actually don't want anything to do with someone who gets a lot of trouble with whatever it is that their heavy use is. Intoxication per se can be seen as something that's stigmatizing. We asked in a WHO study in 4 countries, we asked experts in the 14 countries whether people would think it wrong with various disabilities to appear in public. And here are the lists of disabilities down the left, and you can see that down at the very bottom, the most disabling in terms of whether you should appear in public or not, was someone who is visibly drunk and someone who is visibly under the influence of drugs. And there was some variation, you can see on the right there, among different countries, but generally speaking, this is not, yes, there are cultural variations. Don't take these too literally, because it's a matter of 20 experts telling you what they think is true in the culture, but it still will give you a pretty good sense across a very large number of countries. Third thing is addiction or dependence. Addiction, after all, is a disease of the will, as it's been defined sometimes in the literature. And Edwin Lemert, a American sociologist and anthropologist, wrote in as early as 1957, one of the most vivid and isolating distinctions which can be made in a culture which attributes morality, success, and respectability to the power of a disciplined will is to talk about a disease which is marked by a failure of the will, essentially. It's the dilemma of drugs for the consumer society that, on the one hand, we have an expectation and encouragement of consumption of drugs like alcohol. Consumption drives the economy. A habit-forming consumable is the best driver of all if you're trying to drive the economy. But there's also the expectation of sobriety and clear-mindedness when you're driving a car or when you're working or when you're watching small children. And the addiction concept, I would argue, is actually solving that problem for a consumer consumption-oriented society. It's the reconciliation of the fact that on the one hand, the society wants an awful lot of alcohol sold, and on the other hand, it doesn't want the problems. And so it's up to the individual's loss of control. And I would argue that addiction gets invented in human society around that notion of individualizing the responsibility for the disjunction between those two main impulses. Alcoholism concept was originally promoted to reduce the stigma on the alcoholic and the inebriate. In the context of Alcoholics Anonymous, the sixness concept was seen as reducing the intolerable load of guilt for new recruits. That was its framing within AA. But on the other hand, the alcoholism movement in its external relations, Marty Mann and so forth, were very careful to distinguish the alcoholic from the common drunk. This was a special collection of the drunks who were, had this disease. But as an idea, addiction carries its own stigma. 7 presidents of tobacco companies in the US Congress swore that they did not believe that cigarettes are addictive. In 1994, I believe all of them had lost their job by 2 years later. This proved to be a position that was couldn't be defended and sustained. But it was interesting that for a very long time the tobacco companies tried to argue that no, nicotines are not addictive. So it was seen as stigmatizing. Here's, again, from that study of disabilities where we asked people about the relative stigma of 18 conditions. Here, we basically did them in relative order because we didn't trust what different experts were doing in terms of what scores they were assigning. We only looked at the relationship between them. And you can see drug addiction comes out as the most stigmatized among these 18 conditions, and alcoholism was number 4, below HIV positive and a criminal record for burglary. And again, you can see there are variations on the right. For some reason, alcoholism is sort of middle of the road for Canada, but fundamentally, among the 20 Canadians who were telling us this, this is, again, you know, it shows how widespread is the stigmatization of the notions of drug addiction or alcoholism. And then the use per se can also be regarded as problematic. It's justified in terms of this stigmatization is justified in terms of the risk of harm or addiction. You can see right there in the preamble to the 1961 Single Narcotics Convention, recognizing that addiction to narcotics drugs constitutes a serious evil for the individual and is fraught with social and economic danger to mankind. Anyway, I won't go on much about that because I know that my 10 minutes is a short 10 minutes. There are varied evidences of social devaluation of substance uses. This is a study that was done in Britain and the US and Australia that showed less priority in terms of setting health priorities for trying to solve health problems for tobacco smokers for what were defined as high alcohol users in the, they'd been reading Jürgen Rehm ahead of the game, and for illegal drug users. But disadvantaged categories of people, in disadvantaged categories of people in the deprived districts in Portugal asked about their experiences with the health system. The alcoholics, even more than the drug users, actually found that they had a bad opinion of the health services, if you look down there at the bottom left, in terms of how they were treated, compared with, say, those who were poor elderly or single mothers or ex-prisoners. In terms of the general treatment population, in the general, in treated populations, we find that alcohol and drug users are heavily marginalized. In the US alcoholism treatment clients, for instance, half are not in families, 60% are unemployed. In the Swedish alcohol drug treatment system that we looked at, again, very, very marginalized. And in fact, when you looked in the Swedish data, and I'm not sure you're going to be able to see this very well, but these are a set of nested odds multiple regressions, essentially logistic regressions. And fundamentally, we had a lot of trouble getting this paper published because people said odds ratios of 20. What do you mean? You know, that doesn't belong in addiction. And this is before your time, but but there's huge odds ratios, as you can see there, for low education, for unstable living situation, for being not in the workforce. In fact, the odds ratios in predicting who will be in alcohol treatment are stronger from those than they are from how much they're drinking. In terms of the whether they qualified as high volume or whether they qualified with dependence and so forth. So treatment entry has an ambiguous role. On the one hand, it means that I can say if I'm a heavy drinker or a heavy drug user that I'm doing something about my problem to my various loved ones. And often, you know, in fact, treatment has a vouching function. What people want from treatment is call them up and say, I'm okay, essentially. But it's a signal of difference, of incompetence. So there's always the issue of whether a hidden addict can be better off left hidden. How and well does marginalization and stigmatization happen in the path to treatment? How do we construct treatment services and systems so it's no stigma to enter, and increasing stigma is not a possible outcome? And the factors in stigmatization in the treatment setting can include staff attitudes, can include the labeling effect of the assignment of diagnoses, can include the reactions of others, can include, of course, self-blame. And then, of course, you have what us sociologists spend a lot of time on, which is secondary deviance. The clients do, after all, hang out together and build their own subculture, essentially, which helps reinforce the behavior. So what are the paths forward on stigma and alcohol and drugs? Should stigma be considered in a balanced frame rather than with these two quite separate literatures that I was talking about? When and how big are the negative or perverse effects? Are there non-stigmatizing alternatives for social control? And here I quote from Brun et al., the Purple Book in 1975. We were a bunch of sociologists, although we were flying the flag of public health. And fundamentally what we were saying, we emphasized measures like tax or opening hours or other kinds of restrictions on the market because they didn't single out individuals and subject them to potential labeling. So that I would argue that there's a big difference between a punishment, picking up what we said yesterday, a punishment which is picking out and singling out an individual and subjecting them to punishment, and a punishment which is this is 5 cents more on the cost of the beer, which is not where you can't pick some individual out from it. And that was clearly there in the new public health approach that the Purple Book represented. Destigmatizing addiction-specific services is quite a challenge. Destigmatizing in mainstream services for alcohol and drugs, you know, that's often presented as being the answer, but even in a mainstream service, it can very easily then become stigmatizing. I'm really rushing through this because I know I'm out of time. Social movements to remove stigma. That was the intent of the alcoholism movement in countries like the US, to replace the old moral model, which was how they identified the temperance movement, with the disease model. And the assumptive frame of that was that the disease rubric was less stigmatized than the crime or sin rubrics, but rubrics are not mutually exclusive. You can easily have them together. If you think about the disease syphilis, it's definitely a disease, but it's also got moralization attached to it. The label may change, but not the handling or the social definition. And I give an example there that Johan Edman gave from Sweden. The policy paths forward, in other words, are difficult. And so, you know, like a good researcher, I end up saying more research is needed. The relation between social inequality, marginalization, and stigma in alcohol and drug context, and for that matter, gambling, needs more study. Thinking about possible experiments, not only in changing mentalities, but also in practical service arrangements, and taking advantage of natural experiments. That is, when the researcher doesn't get to control what's going on. Thank you.
Thank you, Robin. We have time for a couple of questions. Peter?
I mean, thank you, Robin. I mean, it's enormously difficult and complex, isn't it? I mean, this is something that you have thought through a lot in your whole life. I mean, what would you personally like to sort of see to go forward to improve the situation?
I think that stigmatization in our field has mostly negative effects, essentially. I mean, yes, you can point to in the area of drink driving, or for that matter, tobacco smoking, you can point to some positive effects. But particularly when you're dealing with heavy users who are accustomed to their use and so forth, it becomes something that merely piles on the negative, essentially. It's very difficult to have some general answer to that. I mean, I think it basically is one of these phenomena that is going to take multiple approaches. It's partly dealing with the staff, making sure that they've thought through how they're behaving. It's, if you're dealing with a clinical situation, it's partly looking outside the clinic at how it looks outside on the street and what, exactly, can people get in there without being observed by everyone? On the other hand, does it look very disreputable, etc., etc. I mean, there are all kinds of levels at which I think you have to work at it if you're really going to be serious about it.
You're in?
A little bit about the different substances, the different psychoactive substances, and especially the current advent of all the harms is attributable to prescription drugs. How do you see stigma playing in there? And a preliminary analysis, which we did for Ontario, was basically that only after it became stigmatized, the harm was going down quite dramatically in the general population. We had levels of 7% in the general population non-medically using prescription opioids in Ontario at a certain point. After the minister said that this is a catastrophe and those people are bad and they're hurting the overall, etc., etc., it went down immediately, and it was de facto just one more stigmatizing campaign.
Yeah, part of my message is to say that this is a complicated area and that it's a mistake to think of it the way that the clinical literature has tended to think of it, as this sort of mysterious phenomenon that descends from heaven. There are reasons for stigma, in certain terms of how societies organize themselves. The question is whether they could accomplish what they want to accomplish without the negative effects that come from stigma. And the answer is not going to be entirely always that they can. But you certainly can, for instance, if you want to reduce the rates of alcohol problems by raising taxes, then you're not stigmatizing anyone in the way that you are if you pick out people and say, okay, they have to show a card in order to get into the nightclub, and we're going to have individual folk who aren't allowed to come into the nightclub and so forth, which automatically raises the possibility of stigmatization. So I think it's a matter of public health taking into account, when it's thinking about the countermeasures, what is the stigmatizing potential of this particular countermeasure? Is there an alternative one that has less?
Thank you, Robin. We need to move on. And now we move to the second presentation and the second appearance of Lingford-Hughes from Imperial College in London, who will talk us about the failure of pharma treatment concerning dopamine. So let me also, I guess now we are online, and for those who are with us online, let me remind you that you can also pose questions to the presenters as yesterday.
Thank you very much. Yeah. I did actually put a question mark at the end of the title, because I think actually it's quite an important question mark, because I don't think pharmacological treatment has failed. It has quite a lot of issues where it would be better, but I'll come to those. So just to emphasize, so I'm a psychiatrist. I used to lead an alcohol program for almost 10 years. I now work in various other drugs, including club drug clinics. So I've got sort of a broad experience, but also really interested in pharmacology, which is, I guess, why I'm giving this talk. I think in this climate, I should disclose that my research funding, I do have funding from Lundbeck, which is a company I will mention during my talk. They were the ones who most recently have owned nalmefene, particular relevance in Europe. And also, as you've seen, I have given talks. None of them have been promotional as per se. It's all been research-based. If you look at where a lot of our pharmacology has come from, and I have focused a little bit on alcohol because that is where actually the most pharmacology is directed, really. A lot of medications in psychiatry, not just addiction, but a lot of psychiatry have come by serendipity. So an effect was found. I mean, I think the story about this, how they took the drug, either whether they were looking for an anti-worming or in the rubber industry, and then went for a drink afterwards, after work, and found out exactly how disulfiram worked. But maybe not quite the nicest way to use serendipity to find out the use of a drug. But of course, disulfiram has been around for many, many years, and it's having a little bit of a renaissance recently as we try to understand some of its neurobiology, not just that it affects the liver. There's been some work, and I've used a camprosate here, natural substance idea, that it is sort of around and how can it be developed and looked at. And again, it's linked very much with preclinical work. But I think the tour de force in understanding neurobiology and how that has really transformed our work in the clinic has been naltrexone. And this was work showing that you could change alcohol administration that went into clinical trials and then sort of into use in the States. And now it is licensed in many countries around the world. So to me, those are the three ways you can pick up natural substances, the neurobiology or serendipity. And of course, serendipity is the one thing that we probably won't really have now. The regulations, I mean, we haven't had what's going to happen with the instance recently in France, but in the UK we had a similar instance with clinical trials. And the amount of regulations the paperwork, it's now taking me at least a year to get regulatory approval to do a study. But where is medication being used in addiction? And I think it's important to understand why you're using medication. So when I'm training medics, I'm saying that there are stages. You might use the same medication, but it's important that not only you understand why you're using it, but the patient or the client, the user, the experienced person, whatever the nomenclature you use, understands why they're taking it as well. Because it can create a lot of complications if people don't really know what the endpoints are. So you might want to substitute for the drug, i.e. give them the drug that they're taking, buying off the street, whatever, to minimise harm, which we talked about earlier. You might want to give medication to prevent withdrawal, serious complications such as seizures in alcoholism. You might want to stop them relapsing, or at least relapsing to very heavy use. And again, there's the preventing complications, which again would be something like seizures, but also preventing infections. And that was a main driver for the methadone maintenance in the opiate substitution field, sort of in the 70s and 80s. But I just want to sort of highlight a few. So substitution is widely used in opiate. In fact, it has been the mainstay. In the UK, we're slightly coming away from maintenance now. And nicotine addiction, that's being talked about a lot already. Less commonly for stimulants. I think it is quite controversial to give somebody amphetamine. In fact, now it's incredibly hard because of regulations that are now being enforced in the UK to actually prescribe and give out amphetamine. What I find really interesting, it's very controversial to use benzodiazepines and alcohol. And people say to me, well, if they take benzodiazepines and alcohol, you get a double dependence, you've got risk of death of overdose and respiratory depression, etc. And I say, but you get all of those with heroin and methadone, but we don't stop prescribing methadone. So I think it's interesting. I think, again, there's a view about where substitution can be used. Withdrawal, I've already alluded to with alcohol, it is absolutely critical for some people who drink alcohol at a heavy level that they have medication, benzodiazepines generally, to prevent life-threatening complications. For instance, somebody having a seizure from alcohol withdrawal, in the UK, they lose their driving licence for a year. That can have a tremendous knock-on effect in terms of their ability to work, family life, etc. You may just give a reduction of the substitute, or you just may give no specific drugs, but you just may give something to sleep or GI disturbance or whatever. And particularly for the substitution, I think this has become the debate with nicotine a little bit, actually. Are you you know, a lot of the e-cigarette, the NRT, was for smoking cessation, but I've got many friends who's treating it as a substitute treatment now. So I think, you know, again, what is the aim? And I think that's important to try and get across to the patient giving it to. But I'm going to focus a little bit on relapse prevention, because I think that's where the area of pharmacology can come into play. So one picture of the brain, which will come out time and time again. And I'm going to focus on this dopamine system. So these are the neurons in your brainstem going up into the ventral striatum, which is kind of in the middle of your brain, and also the frontal cortex. And this dopamine pathway has really been the pathway that everybody has studied. So the classic preclinical experiments showing pretty much for every single drug of abuse to varying degrees can change dopamine levels in this pathway. And I say to varying degrees because for some models you can get rid of this pathway via lesions or medication or blocking or whatever. And animals will still work, say, for alcohol and for opiates. So we do know that dopamine isn't the only thing that is necessary. But it has become the focus, and the pleasure-reward motivational system has received the most amount of attention. So what, in a sense, has come out of this, if you move now to human imaging, this is the brain cut through the middle. This is the striatum bit coloured up here, and similarly here. This is an MR scan showing this is the front of the brain here. This is going down into the brainstem. And if you give alcohol or stimulants and you try to measure dopamine in the brain, which you can do, these coloured areas are where you see changes in dopamine in the brain. And that's, particularly for stimulants, the more dopamine that's released, the more pleasure they said they were experiencing. This is a PET scan, which is also labelling the pharmacology, the dopamine in the brain, and this is actually, again, this is the front of the brain, back of the brain. This is showing actually there's very little dopamine receptors now, the sort of the target of dopamine in the brain in addicts, particularly in alcohol and stimulants again. And this has been really the dogma, so that therefore acutely you increase dopamine, and therefore what you'd want to do is block dopamine function to prevent that high or drug liking or drug seeking motivation. And you'd give a blocker of the receptor, the D2 receptor. And actually, universally, this has been not very promising or helpful in the clinic. But once we realised actually a lot of addicts actually had a low-functioning dopamine system. If this was a high-functioning system, there'd be a lot of red in the image because there'd be lots of receptors. So actually what you want to do is boost dopamine to reduce maybe the dysphoria and irritability that's thought to be associated. And so we now give the agonists, the boosters, of which bromocriptine was one example, and also I've got disulfiram on there because in fact it does alter dopamine levels in the brain as well, but we don't know if that's related to its clinical efficacy. And this really has been the, right, you need to block, but you need to boost. But these strategies have not given us anything robustly effective in the clinic. So I think we need to move away from dopamine. So more recently, Aldobadiani reviewed the literature, preclinical literature, comparing stimulants and opiates, and more recently we produced the highs and lows of dopamine research more in the clinical aspects, saying that there are differences between substances, there are nuances that we need to be understand, and just hitting the dopamine system is not actually very helpful in terms of translating into the clinic. Again, you know, the one sledgehammer is not going to crack all the different nuts that you might want to get at, in addition to the different substances and the different processes. So again, using alcohol as the example, because this is the only disorder where it's really been looked at to any success, if you're now looking at that pathway, we know that the main inhibitory system, the GABA system, which is where benzodiazepines target, those actually modulate the dopamine system. And if you boost this system, either with anticonvulsants or a drug called baclofen, I won't get into the details, those have actually moved into the clinic and shown to be efficacious for stimulants, but also for alcohol. If you go back, another sort of modulatory system, the opioids, which I've already mentioned in terms of naltrexone, that also modulates the dopamine system. And again, we know alcohol and stimulants release endorphins, the natural opiate system. That's related to pleasure, been shown in multiple studies. And again, you can block this effect with two drugs, naltrexone or nalmorphine, which is the Lundbeck compound. And so by understanding this neurobiology, actually we do have useful drugs in the clinic. Other modulators, there's a variety here, but some of them can be used, like varenicline, Champix is used directly for nicotine addiction, but it has also been looked at in other substances. Ondansetron's been around for a long time. I don't think it's really moved into the clinic. Glutamate system, acamprosate targets that, and then we've got the cannabinoid system, and again, it's work in progress. But we have a variety of targets. So maybe the dopamine system may not be dysregulated itself, but we've now got a variety of targets, which obviously is required for drug development. There is actually a wealth of evidence. So I've quoted mainly the UK evidence. I think NICE is often used around the world, and I've just shown an example here for methadone and buprenorphine, for alcohol, and what's that one, the substance misuse in other settings. So some of them can be more public health related. This is what's called the orange guidelines because of the front colour of its the jacket, but that was mainly for everything but alcohol, which I showed the bizarre division between drug and alcohol services. And this is guidelines that I've been involved in over a decade now. Some people in this room have been involved as well, just looking at the pharmacology. So there's a wealth of evidence, and they all support use of medication. However, it's not always used. Even when, so this is the Mesa Grande table, I'm sure many of you are aware of, rating lots of the different therapies used to treat alcohol use disorders, variety of different settings, some clinical, some non-clinical. But you've got brief intervention and motivational interviewing at the top, or motivation enhancement. GABA agonist is actually a acamprosate. It's not a GABA agonist, but then the pharmacology was thought that to be the case. Opiate antagonist is naltrexone. Antabuse is down here, and these are all positive. This is the most common drug, an antidepressants and SSRI, most common drug prescribed to an alcoholic. And actually, evidence that it's not effective is overwhelming, yet it continues to be the most often drug prescribed. So even amongst all these psychosocial treatments, medication's coming out pretty well in clinical populations. If you look at effect sizes, because people say they are modest, and that is true. However, this is a review by Stefan Leucht, which is this is the general medicine. This is actually treatment for Hep C up here, I believe, or this one. But these are the psychiatric drugs, and these are where the alcohol relapse prevention medications lie in. So we've got actually, we're not down here. It's not great, but we do have effective treatments. I'm sure many of you are aware that when you look at the treatment gap, alcohol use disorders, about 1 in 20 maybe is getting into treatment. I think the figures, interestingly, are fairly stable across the world. And of those in treatment, this data is incredibly hard to get hold of. But my reading of the situation from some UK data is less than 5% of those that get into treatment will be offered relapse prevention medication. So it's a tiny minority who are even getting offered, and even less actually get received. So why? I think there is a huge belief about not using medication. I think that's changed a bit, but I think that a lot of the people I work with don't necessarily believe they're effective. They've tried it once on one patient, it didn't work, that's it. There is a huge lack of knowledge in addressing the nihilism. Not only do patients and clients, one of the benefits of Lundbeck coming out, the nalmefene rather getting NICE recommendation, was the press were all over it. Interesting, the BBC went into a pub around the corner from their offices and asking people in the pub whether they wanted to take this drug to stop them drinking so much. And one woman said she couldn't imagine taking a drug that would affect her brain, and took another sip of alcohol. So I thought that was a bit, I don't know whether the BBC left it in thinking it was ironic. Anyway, the staff working in the field, the other thing to say is in the UK currently, there is hardly any doctors being trained or nurses in addiction because they're going to the third sector, which have no responsibility for training and are not mandated to. So training posts are being stripped out. So that's a big issue, because if you don't know about these drugs or cannot talk about them, how are you going to... There is a lack of concern about, there is a huge concern about cost. And whenever I'm asked, the first question I'm asked is, how much is it going to cost? And I think, I'm not saying that you shouldn't rely on this, but for some drugs, for some addicts, you need to consider medication as well. The other issue, of course, is the cost of medication. And this was a report that came out that costed medication sort of development as 2.6 billion, and then this was the article, and this was the press, and this was a commentary in the New England Journal of Medicine. We didn't know what drugs they were looking at, but you get millions of compounds, and you may get 1 or 2 products at this sort of area. So it's a long-term investment, and that's the problem. And of course, for us, In Europe, the big news last year was Lundbeck decided to restructure, and many of the people I've been working with looking at the nalmefene and its interest literally lost their jobs overnight. So Lundbeck decided to go for antidepressants and antipsychotics, neurological disorders, and dropped nalmefene, Salincro, essentially. They haven't dropped it completely, but there are still offices and people working in France, and Spain and Switzerland, I think, is in development. But in the UK, certainly the team has all gone. So this was the only company really actively doing anything about education and about trying to promote thinking about alcohol. And now that's essentially, it's no longer working in the field, certainly in the UK. Like I say, a bit in France and probably in Spain and Switzerland. I just want to belabor the point about where we've got the gaps. So these are for most of the addictions, we have no medication. And I can tell you for stimulants, it's not for the want of trying. I mean, goodness knows how many billions of dollars the US have spent. For nicotine, we've pretty much gone for these substitutes in various guises, but for use for detox and relapse prevention, i.e. if you count being abstinent from a cigarette, but on a substitute, a nicotine substitute as abstinence, and I know some people wouldn't. Opiate addiction, it's all about substitution, a little bit about detox. Apart from giving the blocker, there is nothing going on in relapse prevention. Zero. And I find that really odd. Whereas alcohol's almost the exact opposite. We don't give anything. We give a drug to prevent harm, and we have a wealth of different drugs. And I haven't listed all the ones being investigated. So it's an interesting difference between the different substances. So, last slide. I would argue that understanding the dopamine system has been important, but actually as a clinician it hasn't really helped us in the clinic. But medication with other targets have been shown to be effective. But however, we are focusing on different stages, and I think we need to broaden out. I think opiate addiction, particularly for relapse prevention, we need to understand more. We need to understand alcohol detox better. We've stopped thinking about that as well. But even though it's effective, many people never get offered it. We need to address stigma, coming back to what Robin was saying, nihilism, and the lack of training, actually, which is going to only increase in the UK as we have less clinicians involved in treating addiction, alongside the people who are needed, who can retrain, education, jobs, cooking skills, etc. But we do need the clinicians as well. Thank you.
Thank you, Anne. Time for questions. Robin first. Please try to be short.
Yeah, I mean, the issue of what can be maintained, what can be maintained and what can't be maintained is really something that needs fuller discussion. It seems to be interesting that it's the uppers that people have a great deal of difficulty thinking that it would be okay to maintain someone. This is all about sort of at the level of what the society will stand for, essentially. Yeah. Alcohol, there is actually alcohol maintenance going on in Canada, for instance, where they take old heavy drinkers and put them in a place where they can drink.
We have it in the UK as well, wet houses,
Yeah, so that it's not called alcohol, it's not thought of in a clinical terms, but it is essentially a kind of maintenance, essentially. Yeah. The problem with the nicotine, as we've been discussing, is essentially that when Nicorette was introduced, it was supposed to be, in the US, it was only allowed to be unpalatable. It had to taste like a medicine, not something that you might enjoy. So that there's this whole notion that you can't have maintenance with something which might be enjoyable, that methadone supposedly has no kick, all of those kinds of pretenses that are carried on to be able to keep going with maintenance.
Yeah. I mean, I think maintenance is, as you say, a lot about social norms, societies, what the politicians want. It has very little to do with the pharmacology. And we, like I said, in the UK, we're going towards a recovery mode. And I think it's interesting in the opiate field, people I've worked with people who've never worked with abstinence in the opiate field because they've been trained and brought up in maintenance programs, whereas in alcohol we generally deal with abstinence. I think it's interesting, as you say, it's not societal will, almost a political will. Why not?
Thank you. Thanks, Anne. Great talk. The 92% not treated people, they are often cited as a treatment gap, but from the broader perspective where a lot of people actually spontaneously go back to social drinking norms, What do you? Well, I think it's a broader issue, really. How big is this treatment gap, really?
Yeah. I mean, I would agree. I think you're right. I should have couched that and I forgot as I was going through them. Yeah, I mean, some of those won't want treatment, or at least at that snapshot don't want it. And I guess the older third, a third. But I think we do know that people aren't going into treatment. Certainly, my experience from doing a trial in primary care was a lot of people didn't even realise they were drinking. Their consumption of alcohol was causing their anxiety, depression, whatever it was, GI symptoms, and I think there's a lack of awareness that wouldn't even be counted on that. So, but I agree, it's more complex than just a gap.
Laura?
Laura Schmidt. I'm involved in a couple of studies in the U.S. Trying to boost adoption of these medications in treatment programs, and it seems to me that Vivitrol is when providers and families discover that medication, it's sort of like the heavens open.
Yeah.
And I noticed you didn't mention it at all, but it's a medication that seems, even though it's expensive and tricky to prescribe and store and transport, it's...
So this is injectable naltrexone, just so everybody always wondered what it was.
You're not using it in the UK?
So we don't have it in the UK.
Ah. Too bad.
And I think the interesting about Vivitrol is when you go online, there is quite a lot of, like with baclofen actually, there's a lot of people talk very warmly about it, but the trial itself, yes, showed some effect, but it hasn't broadened out. I mean, certainly some patients in the UK have been importing it, but I'm not aware that it's not widely used in the UK. I mean, there'll be private clinics, but it's not widely. I can't even prescribe naltrexone, let alone the injectable form, sometimes. I'm not asked,
Sven?
Sven Andreasson from Stockholm. We've been using nalmefene and naltrexone for quite a while. In Sweden, nalmefene was never subsidized by the pharmacies, and the reason being that it couldn't prove that it was superior to naltrexone. And in fact, you can use naltrexone on as-need basis as well.
Yeah, exactly how I use it.
Right. The question I have for you is, what are the long-term outcomes? I've seen many studies on 12 weeks of treatment, but what are the long-term outcomes?
I think I would agree with you. There's been no head-to-head for naltrexone and nalmefene, and I use naltrexone just like nalmefene has its license, and actually I find nalmefene much trickier to use in terms of side effect profile. So anyway, but I think the longer-term stuff, as you say, most trials are 12 weeks. There are some that go out longer. But I find interesting about the naltrexone data is it suggests that actually if you stop it, you lose the impact of it, whereas a camprosate seems to endure a bit longer. Certainly in the UK, we advocate that it should be about 6 months or so, but if it hasn't changed drinking behaviour in 4 to 6 weeks, you should stop it because it doesn't seem to be sort of doing anything. I think in terms of long-term adverse effects, I don't think there's I haven't seen any reports of staying on a drug for 1 or 2, 3 years has anything that we need to worry about. I mean, people worry about liver function with naltrexone, but actually it's fine.
We find that about 60 to 70% derive no effect whatsoever from either of these substances. Is that your experience?
Yeah, I mean, I guess, I mean, I tend to give naltrexone to the samplers. People who have occasional drink, I give a camprosate. I have a slight kind of algorithm, but I would agree that, particularly with when I was trialling nalmefene, I would say about a third got some immediate benefit from it. And I think you get an immediate benefit often in the first few weeks, which persists. And actually, they often don't need a second or third prescription because they've made enough changes. So they don't want to be on it long term, a lot of people. But it's tricky. Okay. We need predictors, and we don't have them.
I would support this thing of adding extended release naltrexone, even though it's not useful in the U, not approved in the UK.
Yeah.
But in talking about these 3 medicines, buprenorphine, methadone, and now Vivitrol, I think it's good to say none of them cure addiction. They sort of stabilize it in different ways. Because when you take people off, the relapse rates are quite high. So, it's useful like a lot of other medicines are for chronic conditions. Yeah. And the cost, though naltrexone is, the individual dose expense, the overall cost may not be greater because you don't need the big infrastructure. Yeah. And where it fits in, like people coming out of prison, they typically get detoxified in many countries. In the U.S., it could, even though they may not take it for the next 5 years, like some will for methadone, it could prevent them from relapsing and overdosing in that immediate, and give them time to get into.
But we know with the opiate addiction, opiate addicts, routinely do not take naltrexone. It doesn't give them anything, and this is where I would argue the relapse prevention. So in the UK, often people are retoxed before they're released from prison to prevent the deaths, because the death is an outcome, and our death rates are going up.
Right.
Why aren't we thinking more broadly? How can you protect respiration? There's some 5-HT stuff that's going on with the pain literature, which it's that kind of thing. I think we need to be thinking more broadly about what is the relapse prevention, what are the targets, how can we do it? And I don't think we are thinking broadly enough at the moment, other than give the substitutes, because they're there.
Yeah, if you start them on methadone in prison, it has to be continued immediately after they get, or you're right back to where you started. And naltrexone gives them that extra time, and that could be valuable.
But often they're not. I mean, my experience in the UK is they don't take it, and then they.
We take a last.
Well, if they get a shot before they leave, they get it for a month.
Yeah, that's true. That's.
We take a last question.
Sorry, I don't waste time.
This is an online question from Susan from London School. Is the lack of training now appearing in the UK also the case in other European countries, or is this a specifically British problem?
I don't know. I don't know what's happening elsewhere. Jürgen?
We've just made a... just made a survey in 6 different countries, and the lack of training is constant in Europe. It's we are speaking about 4 hours of addiction in university training on average, something like that in most countries. So the countries were France, the 6 biggest EU countries, and the lack of training is really universal.
Can I just say, medical school, that's absolutely correct. I think what concerns me is that once you become trained, whether it's a nurse, doctor, psychologist, very few are not getting any exposure to addiction. So I trained initially as old age and kind of took a right turn into addiction. So we're not going to capture any bright young things or people who hadn't thought about it. The nihilism, the stigma is just they're not going to take it as an option. The majority of consultant psychiatrists in the UK have no addiction training as a practicing doctor. Yet most of their client load has a substance misuse.
I think this sounds familiar to many of us.
Exactly. And I'm not saying it's just psychiatrists, it needs to be medics as the end.
And now thank you very much, Anne, for your presentation. We'll come back with more questions if we have time, but now we need to move on to the last presentation. That's this one is from Italy. We have Fabrizio Faggiano working in Novara in the University of Avogadro, who will talk about a new European agency towards the European Prevention Agency. Thank you.
Okay, thank you very much. I will try to answer to the question of yesterday, if there is a need of an European Prevention Center. The first slide is about the paradox of prevention, because everybody agree on the fact that since addiction is a chronic relapsing condition, theoretically the most rational intervention should be prevention. But in fact, in spite of numerous systematic reviews published and of the rhetoric claims of any policy in favor of evidence-based prevention, the real coverage of the target population with effective prevention is absolutely unknown in Europe, and not only in Europe. So it's appeared that we are abdicating to prevention, in fact. I tried to focus on the coverage in order to try to describe which is the level of prevention activities in Europe. And in fact, I didn't find any national dissemination prevention report about prevention in Medline or in a Google search. I found just a couple of papers from US from describing the school-based prevention intervention in a large sample of schools. And in fact, these reports reported that 56% of schools have any kind of program, and 5.7% of schools, in fact, adopted an evidence-based program. So probably 95% of schools do not have evidence-based programs, and probably 50%, no, 90% of programs are not evidence-based. In Italy, we have only one survey in 2009. This survey showed that for the four risk factors of gaining health, there was 1,500 different prevention interventions in 1 year from the health service. It's absolutely crazy because it's like 400 different interventions for every risk factors. But what is interesting is that 14 were evaluated by observational studies. 1 was evaluated by a randomized control trial. So 1,486 interventions didn't have any evaluation. And this, I probably think that is the situation in Europe, not only in Italy. The only real survey that is carried out in Europe is carried out by MCDDA, but in fact it's not a real survey, it's just a question to the RATOX Center. Have you any evidence-based prevention intervention in your country? And the answer is yes. So in practice today, prevention is characterized by a low coverage with programs mainly with no evidence of effect. So it's clear if you have a low effect with a low coverage, the impact is very, very low. This is the reason why it is difficult to still believe in prevention. But I think that it's too early to renounce to prevention because we are assisting to the beginning of the scientific revolution. As for treatment 30 years ago, I don't know if somebody of you remember, but 30 years ago in the clinical setting, the situation was the same. No evidence-based guidelines, no systematic reviews, and the medicine was seen as an art, not as a science. And what are the reasons for this renounce? Probably there are a skepticism about effectiveness. And this skepticism this nihilism is caused by complexity of prevention paradigm, by of the theoretical background of intervention, and also by the misunderstanding about the level of action, because there is a misunderstanding between the notion of program, of intervention, of component, technique, and theory, because if you look at systematic reviews, or if you look also to very interesting websites like that of evidence-based medicine of the MCDDA, the focus is on technique, is on, for example, on life skills intervention. Life skills is a technique, is not an intervention. Or on the theories, on social norm intervention. In fact, what is effective is the program, is not the theories, the technique. Because if you look at the systematic reviews, there are very good intervention, very well based on theory and using the most modern theories that are not effective at all. So, what Ellis Rapp have discovered, only about 37% of prevention programs submitted to scientific evaluation are effective. They are based on a large set of theories. They use an extremely variable set of components whose separate analysis is never evaluated. And trials usually assess effectiveness of programs as a unique intervention and not consider components. Let me focus on effectiveness. The first conclusion is that not all interventions are effective. Looking at a review conducted in 2013 in the Cochrane reviews on prevention, and looking on all the intervention for the primary prevention of alcohol use, intravenous drug use, and tobacco use, there are more or less 350 interventions. Only the 37% are favoring intervention. There are a 5% of intervention that are favoring controls, so they are iatrogenic, and the most part, 58%, are not effective at all. Yeah, and this is not surprising because we saw in the last presentation that in order to have one effective medicine, industry developed 5,000 to 10,000 compounds. So probably we have to be happy in prevention, because in our case it's 1 out of 3. It's not 1 out of 10,000. But in any case, this is the situation. Trying to identify all the intervention that are effective in the prevention of alcohol and drug, we selected 13 interventions. These are the interventions that we selected. The first thing that we can see is that they are mainly from North America, from US. There are a few interventions from Europe, and they are mainly school-based and sometimes family-based. These interventions have been submitted to a work to try to extract from them the base theories with the help of the systems of the authors, and also to classify and aggregate these theories, and to extract the compounds and the components and the mediators of the intervention. And these are the results. Looking at theories, you can see that there are a lot of different theories that are declared by the authors. We decided this, the last month, to include a new intervention, this community that care, for which we don't have all the information filled in, because it's a very interesting and very new intervention. And this is the reason why there is that line, this line that is empty. But for the others, you can see that there are, most interventions are based on many theories. These are the other line, the other table. Strengthening Family Program is the only effective intervention for which the authors do not accept to collaborate with us. So at the end, we didn't, we were not able to extract the theories, because the theories have to be validated by the authors. This is our attempt to try to classify all the theories in 5 major general theories that are social learning and social cognitive theory, theory of planned behavior, social norms theory, social control, and problem behavior theory. So you can see that most part of the intervention are based on these family of theories, but sometimes they use more than one set of theories. This is the other work that we did. We described the components, and the components is the number of components is very variable. You can see that there are programs with 1 component and programs with 40 components. A component is like a unit. Sometimes it's also more than a unit, but targeting to a specific mediator. And this is our recategorization, aggregation of components on the base of mediators. These are the main mediators of the targeted by components: drug skills, generic skills, knowledge, beliefs about substances, perception of pressure, and class management. And once again, you can see that there are the map of the components mediator is very different. These are the components of specific components of the parent component of the intervention. A first conclusion is that effective programs for drug prevention appear to have a little in common, to be all, and this is a specific conclusion, to be all a development of the first influential program, the life skills training from Botwin, without a process of linear scientific development. Everybody is based on the same program. There is not an accumulation of knowledge, apart 2 exceptions. There are only two exceptions that are good behavior gain, and prevention. Prevention is the program, is a selective program. Good behavior gain is a very old program based on class management. What is not working in what okay, thank you, in what I explain, what is not working is that usually the process of evidence transfer is based on the production of innovation, evaluation, evidence-based, and then practice. Promising intervention are evaluated, then evaluation is put in is made available to practitioners, and then practitioners adopt the effective intervention in their practice. But in our field, probably there is not this phase, and we go directly from innovation to practice. In fact, what is complex is that, is that now the current methods to guide the translation of evidence in systematic reviews to the selection of a specific intervention within a class of intervention are poorly developed. In summary, there is neither an evidence-based nor any process to promote the use of effective programs. The proposal that we want to make is that Europe needs a central and transparent approval process for behavioral prevention intervention, a process that should include all the prevention intervention, reactive, not proactive, based on scientific requirement adapted to the type of intervention, evaluating effectiveness but also readiness to use, and providing access to manuals or to operational instruction. Something like the process of approval of drugs, starting from the efficacy of single components, then efficacy of a combination, effectiveness of intervention, approval of the intervention, and then continuing with a phase 4, trying to extend the concept of effectiveness to other contexts. So it's an European Prevention Center, probably, I don't know, or it could be also a network of researchers and practitioners accredited by, for example, an European agency. It could be MCDDA, the European agency. But the problem is that this kind of problem is common to all the fields of prevention, not only the field of prevention of drug use. So probably MCDDA could be limiting could limit the ambition of this agency. So my final remark is that the impact of prevention is perceived as lower than that of treatment. And this is partially explained by the delay in development of prevention science. To find a path toward a stronger scientific base of prevention, it is an essential step, and an European Prevention Center could make a U-turn. Thank you very much.
Thank you, Fabrizio. Let's take a couple of questions first, and then we will have the rest of that. Joan.
Hi, Joan. I'll be from Barcelona. Thank you very much for this presentation. And I like very much the parallel to the development of new drugs. And in fact, what I was going to ask you from our experience in this city, where we've tried to push for a certain coverage of some preventive interventions in school-based that are evidence-based, is the other things that go beyond the approval of a new drug, and that is to what extent it is used, it is prescribed, and what's the driving force in it when you don't have the market pushing for profit, and also compliance with the prescription, because another issue is to what extent an intervention that requires 12 hours of classroom involvement is applied for 12 hours or only for 2 or 3, and the rest is not really performed, because those are issues we also have to deal with.
Yes, I agree with you, but I think that this kind of problems are a country-specific problems. It's a health service-specific problems. It's every health service that have to decide which is the best strategy in order to disseminate to ensure the compliance and the quality, ensure the coverage. At the European level, we need something that identify what is have to be disseminated and which is the level, the standard level of quality that is expected. It's like, for example, once again for drug approval, we have the EMA, the European Medicine Agency, but within every country there is a specific designs of a health system or a strategy to improve quality in order to ensure the quality, ensure the coverage, etc., etc.
Robert?
Hi, over here.
Yeah.
So just a sort of methodological issue in terms of how one can aggregate data in this area. I presume because of the heterogeneity, you chose really to say, well, these look effective, these look possibly actually counterproductive, and these look potentially neither effective nor otherwise. I think even in an area where there's a lot of potential heterogeneity, it still potentially makes sense to analyze the data using, for example, Bayes factors instead of the classical approach, so that you can discriminate between a study that you can see to what extent the study is tending in a particular direction, but the data are insensitive, versus the data genuinely support the idea that there's no effect, or that there's an effect in the other direction. I wondered whether you had thought of, or whether you had already applied a Bayesian approach to these data, which might, I think, give greater clarity. Because, for example, it may be that if you look at the studies as a whole, the effect sizes follow a distribution, and there isn't sufficient heterogeneity in outcome to be able to say with confidence, these ones are the ones that have the right components, but rather you're sampling from a distribution which actually is the same distribution. It's getting that distinction that's very... Does that make sense?
Yes. What do you mean with Bayes approach?
Oh, Bayesian. I don't know how...
Bayesian, okay,
yeah.
Fine, yes. I think that you are right, but you have to take into consideration that the systematic reviews, we took the data from the systematic reviews, and we analyzed every randomized control trial included, so after the process of quality, and we used these results and the evidence from the significant level of the results in order to put in the classification effective, iatrogenic or not effective. It is very difficult to aggregate these results because the most part come from different interventions that are really, in the point of view of heterogeneity, you could not put together. It's like, for example, if you have to analyze the effectiveness of drugs to treat hypertension, putting together all kinds of drugs, you cannot do that.
No, I think you're right. I mean, I completely agree with that. I think it's just when it comes to then analyzing the results of the individual studies, if you calculate Bayes factors, for example, then you would know. I would be interested to know with the ones that are classified as iatrogenic, are the Bayes factors really pushing you in that direction? And the ones where there's no effect, are they really no effect, or are they just the data are insensitive? It's getting that sort of quantification that seems. It just seems nowadays, this is something that's open to us. This is a tool that we have the computational power to do.
We didn't you didn't apply this approach because we made a very extensive research on all the interventions for the primary prevention, and at the end there was 53, I remember, 53 interventions. So it's a very, very big work. Probably we have to apply a Bayesian approach to do another step ahead. Okay.
Thank you. Sven, and then
we carried out a major trial in Sweden in 2004 to 8, where quite a lot of funding went into a trial where a number of communities were given a menu of different effective programs, pretty much resembling what you showed us here, and we had a number of control communities. we found no effects. That's the bottom line. And in Norway, similar trials went on with the same result. What we discovered was that these programs are actually quite complex technologies. They require a lot of training. They require supervision, technical expertise, and backup. And most of the communities don't have those resources. So my question to you is, we're familiar with the literature on efficacy trials. What about effectiveness trials? Can you tell us something about what happens when you actually go into real communities with these programs?
There are few studies like that you described, because the most part are more smaller trial, like randomized cluster trials. There are others like community that care or strengthening family program that involve more than one setting, and they are much more complex. My idea, at this point, I'm very pragmatic. My idea is that in any case, if one intervention can be submitted to a trial and can produce positive results, this indicates that the intervention is effective, and also that it can be translated to the practice. If an intervention cannot be submitted to a trial because it is too much complex, it is not an intervention that can be proposed to the practice. Because my point of view is a point of view of public health, not of a scientist. I need an intervention that has to be disseminated to all the population. If the intervention is too much complex and I cannot submit to a trial because it is too much complex, this is not a good candidate to become one intervention to be disseminated to all the population.
Okay. We'll take two more questions and then we open to the rest of the speakers. Ian and then Lydia.
Your approach is clearly about preventing uptake rather than necessarily preventing harm. And some public health approaches like mass media campaigns for smoking of proven efficacy presumably work both by reducing uptake but also by helping people to stop. If you do set up a European prevention agency, would you wish to include the broader aspects of harm prevention?
Yeah, absolutely yes. I think that it's very interesting because there are specific techniques to evaluate these campaigns. And for example, there is this big example about the national anti-drug campaign in the United States from 1998 to 2004 that is have been very evaluated with very rigorous methods and show iatrogenic effects. So I think it's absolutely essential to evaluate and to include in some sort of approval process also this kind of interventions.
Okay, may I ask now Robin and Anne to join us here so we have final round of general questions to the overall session. Peter has a question. Okay.
Thank you. This is a question to Anne and maybe others in the room. The Lundbeck is a very sort of interesting case study. I mean, presumably they've sort of dropped the kind of overall approach to nalmefene for commercial reasons. So what was driving that commercial reason? Was it lack of perceived effectiveness? Was it lack of uptake? What was the problem?
I don't know. So I don't, although I've worked with Lundbeck, I don't know the reasons they took that decision, and I don't feel I can make a statement kind of saying what I think, because I actually don't know. I think the message that got out in some areas of the media about it was that compared to, say, schizophrenia and depression, addiction wasn't worth, it didn't have the same status. And that I thought was more troubling, actually, because this feeds back into stigma again, that actually somehow it's of a lesser issue, and that I did think unfortunate. But the reasons behind Lundbeck, I mean, yes, a lot of the financial was in the media, but I don't know why they made the decision about nalmefene.
I mean, the implication is that it wasn't then just, I mean, you can't answer this, I presume, but the implication of what I heard from you is this just wasn't just a financial decision, it might have been a reputational decision as well?
No, no, I didn't mean that reputational at all. What I think the issue, I think it was how it was, you know, and it's not Lundbeck, it's how it was perceived by other people, that somehow they were ranking it sort of low, and that I think has been an unfortunate corollary. I should say, for those of you who don't know, this is set in the context of pretty much all of pharma moving out of psychiatry whole, you know. So Lundbeck are about the only active European company, I would say. So in the context of that, I mean, at least they're still in above the net kind of stuff compared to a lot of other. So it was in the broader sort of context, I would say.
This is just a quick aside, really, about the history of Reckitt-Benckiser and buprenorphine. So Reckitt-Benckiser makes Mortein and other household products, Dettol, and they happen to have buprenorphine. They've now set up a new company in Divior that is dedicated to alcohol and drug-related medications, and they will be pursuing, you know, long-acting naltrexone and a variety of other products. And it's fantastic to have a drug company that's saying we're in the business of working with people with substance use disorders.
And I think, I mean, there are a few companies that have been active and, as you say, newer companies. I think what's different now is they are going to be small specialist type companies, whereas the focus, my understanding of pharma is that, you know, more and more big companies, you know, they merge and merge and merge. The one thing I just would like to say, I want to be very clear, when I talk about using pharmacology, it's always, always, always as an adjunct to psychosocial. Absolutely. You know, if a patient comes to me and says, I don't want to talk to you, I just want medication, I say, thanks very much, I'll see you when you want to talk to me. It's the two are in combination. So I just want to emphasise that.
We have a couple of comments from the audience abroad. So, Sylvia, can you...
we have two questions to Robin. Do you want me to tell the both of them at the same time, or I will start with the first? Okay. So the first question is from Susan from London School. How do you explain the apparent lack of stigma connected with the use of stimulants, cocaine or ecstasy, for example, among better off or rich groups?
Sorry. Evident lack of stimulant.
Evident lack of stigma connected with the use of stimulants among better off or rich groups.
What was the last bit? Among rich people. Rich people have always been exempt. I mean, you can look at the history of it. Essentially, rich people are better protected from stigma, essentially. You know, if you look at who it is who shows up in child protection agencies in Australia, and I believe in any European country this would probably be true also, the families that are under observation, that show up in child protection agencies where it may be indeed that's because of the drinking of a carer or something like that, you know, they're from families that are under the gaze of the state in one way or another. If you're rich enough, then you can protect yourself from being under the gaze of all of the professions that have to report to the state if they think there's something wrong with how the children are being looked after in the family. So that fundamentally, you know, there's a very strong class element, I think, in who gets stigmatized and who doesn't.
The second question.
So the second question is from Alaman Alamani, who says, both suffering and stigma are inevitable in our life and also a way to enter treatment, so that the issue of punishment or control may somehow be inevitable. Would it be that the issue of meaning and search for meaning in your life, of both a problem and its treatment, is one way of transforming stigma into a sort of positive value? Thank you.
Well, Alaman is the clinician, not me. But I mean, what I tried to say in my talk is that we can't simply take stigma as being a negative. You know, that it's got, you know, it's got various social functions. It has negative consequences in particular areas. Certainly, when if you look at Alcoholics Anonymous history, for instance, and listen to how people talk to each other in Alcoholics Anonymous. They kind of make a joke of us as a bunch of drunks, essentially. They essentially take on that negative, stigmatized role and turn it into something positive. And you can see that happening again and again with essentially outcast groups in one way or another. So that the whole issue of how stigma relates to how people live their lives and so forth, I think is really complicated and can't be dealt with only in one direction, essentially. So yeah, think about it.
Alessandra?
Thank you. Alessandra Liguori from Unigri. I would like to thank Professor Room for this really inspiring presentation. Thank you very much. I think that all that has been discussed in ELISRAP during these days should be seen through the lenses of this presentation, because all the I'm not a doctor, I'm not a physician, but all the concepts that have been brought to the attention and will be brought to the attention of the European Union and national governments, the concepts that were developed in ELISRAP, like the heavy use over time and everything else, must be considered, and Peter is right that we should have more time to now consider all these concepts through the lenses of the consumer, through the lenses of the individual person, and through the lenses of access to health, access to justice, and access to individual freedom and the right to individual freedom. So the impact that these ELISRAP concepts, I would like to continue this discussion to see how will the impact is going to develop regarding these concepts, and the impacts on these concepts that I just said, in light of the genetic and the evolutionary studies that were brought in the discussion, but also in light of the economic impact that this concept will have. For example, heavy use over time will have an impact on access to treatment. Will the governments decide that only people who have reached the last stage have a right to access treatment? Where the money will be put by governments when we tell them, to consider addiction in this way, and so on and so on. All these, also the stakeholders studies and the analysis that I have seen, and the marketing studies, we have considered from the point of view of the substances, we should consider concepts such as affordability and accessibility to substances, also from the point of view of prevention and treatment strategies. I'm done.
Thank you.
Okay.
Can I just say one
to Fleur because
very short comment?
Out of time.
Is that can
very
I
short
make very
comment?
short?
Then George, then Lydia, and then.
If there's going to be a European Prevention Agency, my argument would be that it ought to be a little broader than was implied in your talk. You talked very briefly about environmental interventions. There, in fact, is a quite substantial European tradition, mostly from Northern Europe, of studies of environmental interventions. What happens when in Geneva, when the alcohol sales places closed earlier, etc. So that, and so we shouldn't. The European Prevention Agency shouldn't be designed around a particular set of professions or a particular set of environments. It has to be seen more broadly, I think, and reaching across Europe, because there are very different strategies in the different cultures that cultures feel comfortable with. Alaman and I have lots of discussions about that.
We'll have a very short question from Lydia, another one short question from the internet, and we will be finishing here.
Actually, some comments.
Oh, sorry, you were first. I'm very sorry. You're so near. George goes first, sorry.
Just a comment about changing situation with medications. That in Indivior, it's public information, I believe it is, that long-acting buprenorphine is due to be presented to the FDA, I think in the fairly near future. And, you know, Vivitrol is been an addition, and it's growing in some countries. Janssen has rights to sell it in Russia and former Soviet states. I got an email from Iran the other day. They said they've gone too far with methadone and they want to do a study on Vivitrol in Iran. I thought it was sort of interesting. So the things are sort of changing. The economics, buprenorphine has been a huge money maker, though it was slow getting started. And Vivitrol is now in the black, so I'm told now too. So things are changing with this medication development issue.
I mean, I would agree they are changing. I think it's
No.
I think I would agree they are changing. It's taken quite a while. I think that's it. And I think I would say this because I'm trained in pharmacology, but I think the lack of knowledge about a lot of the people who are actually divvying out these medications, about how they could be used better, more optimally, in what dose, and all of that side of it would help us make the treatments more effective and targeted. Because I think at the moment they're given out in a bit more of a blanket way, that without the nuances, which means that people, unfortunately, both patients and the providers are getting the experience this doesn't work. But I agree with you. It's interesting what countries don't have methadone but have buprenorphine, and even the range of benzodiazepines available for alcohol detox. It's incredible worldwide how different. So there are some differences, but we don't tend to understand those differences enough and how they inform the more global picture.
Yeah, actually, I want to make some comments. It reminds me when I decided to be involved in addiction field. I'm a clinical psychologist, and the main reason was that I saw really that medications alone couldn't solve the problem of addictions, and that I thought as a clinical psychologist I cannot give something to this field. And I was lacking a little bit reference to the combination of medications together with the psychotherapy and other approaches, because I really think Alice Rapp at least should point about that. And I would like you to, Robin, to reflect a little bit on gender and stigma, because this is even more problematic. And I just want to, for Faggiano, I want to insist on something that Joan and Sven was mentioning. It's not only, we have a first problem is not evidence-based programs are implemented. I mean, we should work on that. But in addition to that, and if there is an agency, I would like to see more also guidance on how to implement evidence-based programs, because Sven mentioned some problems and the sustainability of programs. We have been working with one primary healthcare program for more than 13 years, and we have a lot to still. If you want to do a nationwide prevention program, you have to sustain the program, you have to and overcome a lot of the difficulties that not only lack of training, but lack of rotation of professionals, then you have to train again, and producing changes by doing prevention programs takes a long, long time, and you need a government that keeps supporting the strategy, and it's not easy. So I think this would be another key pillar of an agency if we ever have one.
Thanks, Lydia. If you want to comment shortly on what you said.
I agree. I mean, but you were wanting to say something about the agency.
Yeah, quickly. It is clear that if an agency has to work about the identification of the best intervention, this intervention have to include also environmental intervention. And probably the methodological approach of the agency have to be adapted to the kind of intervention. It's clear that it's different to evaluate a school-based intervention or a policy or a taxation policy. But I'm convinced that all these kind of intervention have to evaluate it by a probably different set of experts, and have to produce a report on the effectiveness, but also on the sustainability and transferability. These are very important points. My idea is that these agencies have to produce a manual, or producer to take from the authors a manual of how to disseminate, how to implement the intervention in order to ensure practicability, but also standardization of the dissemination.
Just one comment about the interaction between the psychosocial, psychological processes and pharmacology. I mean, I think it's true to say that if you have a very pronounced effect from the psychological or psychosocial approach, you are less likely to see the medication have an effect on top of it. That comes back to a question about what's real world versus effectiveness versus efficacy. A lot of these programs that are offered in those trials we wouldn't get in day-to-day service. And obviously people going to a trial are going to be more motivated, etc. But when you start to drill down what trials there doesn't seem to be any particular combination for any particular drug or even a particular psychosocial that is the best one to put with pharmacology. What seems to me is that as long as you're doing a form, and most people get an eclectic mix anyway rather than something very prescriptive, and you're doing it well and the person's engaged, that's the key bit to go with the medication. So there isn't anything specific or magical, you know, about one particular combination.
Okay, before we move to lunch, I'm sorry, I will not take just the last question from the internet. Oh, no? You were? Okay, then we can take yours and then Jan, go ahead, because I thought there was one.
Part of the question that was not answered in respect of gender.
To gender. So,
okay.
Robin.
It's a very large topic, essentially.
But it's lunchtime.
And there are big differences. I mean, this is not only to do with Stigma, but there are very big differences in Europe if you look across the map of Europe in terms of the gender ratios, you know, for instance, heavy drinking to start with. You know, so clearly in some parts of Europe, women come under more stigmatization for heavy drinking than in other parts of Europe. I mean, I don't have anything very specific to say about it, I'm afraid, other than to say that this is an issue that is a general issue for all our societies, not only around addictions or heavy use over time, but where it becomes particularly marked, obviously, in some circumstances. So I'm not being very helpful.
Thank you. Well, I think you're right that this is an issue which is much wider than in the addiction field, for the whole of society. I'm quite impressed that being lunchtime and after such a long day, we keep on asking questions, and my task has been really tough trying to push. We are 15 minutes late, but still we have 1 hour and 15 minutes for lunch. So we'll be back here at 2. And thanks a lot to all the speakers for these brilliant presentations and to all of you for being here asking very good questions.